Is it going forward? Are the slides going forward?
Yes, doctor. Yes.
Okay. Okay, so hello everyone. I'm Dr. Ayush Pandey, and as already we just said my introduction. So the topic for today's session is again an interesting one, pneumonia. We'll be discussing about the types of pneumonia and all the specific management guidelines related to it. So let us go ahead with our session. So as you know, if we talk about the definition of pneumonia and what exactly it is. So it is an important clinical condition commonly, confronted and has been dealt by both a pulmonologist and a general practitioner, and also along the intensivist, people working in the ICU or in a OPD setup. It is very common, with every change of weather or in any season, getting a bacterial, viral pneumonia or fungal pneumonia. Variety causes can be there. So you often deal with this problem on and off. So despite being the cause of significant mortality and morbidity, pneumonia is often misdiagnosed, mistreated, and underestimated. It is again sad because exact definition, exact, uh, diagnosing this pneumonia, exact diagnosing the disease, and again the treatment, what exactly is the treatment, and again underestimation leads to an increase in mortality and morbidity. So what once was a manageable case becomes a unmanageable part once the patient, goes here and there and do a doctor shopping, or maybe going to a quack and then comes to you. It becomes a very, difficult and a critical case. So many studies have shown the topic of CAP. What is CAP? The CAP is community acquired pneumonia. And numerous societies have published their guidelines. So there have been a lot of guidelines. But again, if we talk about the international guidelines which has been given, they have been definitely given by the European Respiratory Society, American Thoracic Society, British Thoracic Society, and again, Indian Chest Society and National College of Chest Physicians, along with the Canadian guidelines. So in spite of this, all the informations, all the guidelines we have from the specific international societies, sometimes again it becomes a challenging, when you have to make a critical decision and exactly how to diagnose and exactly what line of approach should be there, because the patient gives you so very less buffer, or there has been a millisecond to microsecond thing is going on when the patient is in a critical care or in a ICU setup. So that time, you have to be on your toes 24/7. You have to have your senses working 24/7. So the process of frameworking this, national pneumonia guidelines, there was a, study which was being done by the PGI Chandigarh in collaboration with the Indian Chest Society and the National College of Chest Physicians. So again, they collaboratively, did this study, and some of the studies and some of the help were also taken from the departments of, microbiology, internal medicine, pharmacology, and radiodiagnostics. So mainly it was done by the Department of Respiratory Medicine, and then there was a joint collaborative effort by the various departments. So again, classification of level of evidence, if we talk about the grading of recommendation based on the quality of evidence. So level 1, high quality evidence which is backed by consistent results. So this is exactly, the levels are based on the, various randomized controlled trials and what was the outcome for that. So level 1, high quality, you have a high quality evidence. There was a, very well performed trials or drug trial research based on these studies. It was being done. Level 2, it was a moderately random controlled trial. Level 3, a comparatively less low quality trial as compared to the level 1 and 2. And again, then based on this, there was a grading of grade A and B, which was being given. So grade A was strong recommendation to do where the benefits clearly outweighs the risk for most, if not all patients. And grade B, weaker recommendation where benefits and risk are more closely balanced and are often more certain. So based on the quality of evidence, based on the, you have randomized control trials, the results which you have output from that, this classification of the levels of evidence were collected. So now coming to the first type of pneumonia, which is the community acquired pneumonia. So what exactly it is? So community acquired pneumonia is not just basically a clinical and radiographic. It is not just basically either a clinical or a radiographic finding. It is a collaboration, or it is a club of both. So a doctor should diagnose a community-acquired pneumonia or a CAP, both clinically, and if your clinical senses are very good, and I'll tell you, you don't need a secondary radiographical investigation. The radiographic, the diagnostic, the investigations, the blood cultures, again, sputum cultures and everything will definitely tell you about the type of organism. But to diagnose pneumonia, you can definitely do it on the basis of your clinical and radiographic findings. So in the absence of a chest radiograph, when the whether if you are working in any remote setup where you don't have access to doing a chest x-ray, so symptoms of a acute LRTI, cough without expectoration, shortness of breath, and a pleuritic chest pain. What exactly is a pleuritic chest pain? So there is a pleura which is there in a layer which is there outside the lung. So if you have a pneumonia, if the pneumonia comes with a synpneumonic or a subpulmonic effusion, there is touching of the pleural surface along with the parenchymal surface, and then the pleura also gets involved, and because of that pleura getting involved due to the bacterial or any other type of pneumonial infection, there is the pleuritic pain which is present. So this all symptoms should be present for a less than 1 week, and with this you have a and. If you see that it is highlighted in that red letter, so and is very much important. Along with this, along with the LRTI, you need to have at least one systemic feature, that is temperature greater than 37 degrees Celsius, chills, rigors, severe malaise, and again, and new focal chest signs on examinations like bronchial breath sounds or crepitations or crackles. So there is, when there is a pneumonia, the classical, auscultatory findings you can get is communication of the bronchus with the, affected lung parenchymal surface. So you get a sound of bronchial breath sounds along with crepitations due to buildup of fluid, which is there in the pneumonia. So that fluid produces that bubbling sound, which is known as crackles or crepitations. So, or with you don't have any other explanation for illness. So the patient has fever, chills, rigor, you have pleuritic chest pain, shortness of breath, cough with expectoration, and you are unable to find any explanation for any other illness. You are having a bronchial breath sound and you are having a crepitations. Definitely, this is a pneumonia. And again, based on the history, you can correlate again whether it is a community acquired pneumonia or not. So when a chest radiograph is available, CAP is defined as symptoms and signs described with new radiographic shadowing. You can see the arrow which is being present there. So it is a new radiographic shadowing for which there is no other explanation. So this radiographic shadowing is not caused due to either a pulmonary edema, maybe either a cardiogenic or a non-cardiogenic, which can again also lead to buildup of fluid or any pulmonary infarction also. So if or a radiographic shadowing may be seen in the form of a lobar or a patchy consolidation, loss of a normal diaphragmatic or a cardiac or mediastinal silhouette, interstitial infiltrates or a bilateral perihiral opacities with no other obvious cause if you find it. So it is, very commonly if you have a chest radiograph and if you are able to do it and you see this, new radiographic findings for which you don't get any explanation. So now, if I can ask from the audience, can any one of you describe this X-ray? What exactly is this X-ray? If you describe it, how would you describe this X-ray? Anyone? Anyone? You can type in the chat box if you can describe the chest X-ray. This is a very classical, representation of a pneumonia, and it is mostly a lobar pneumonia. But again, if you classify or if you want to say this, that what exactly is this X-ray, so there is a opacity which you see this, and the opacity is well whitish kind of opacity. So mostly it is a heterogeneous opacity because also you see there are areas of blackening which is being present. So area of heterogeneous opacity again involving the parenchymal, some part of pleural involvement is also there, with involvement seen mostly in the right upper and lower zone. Consolidation pneumonia, yes, right mid lung zone. Shaila, you are right. But again, I just wanted you to interpret this X-ray. It would have been more. So Basically, reading, we are not going into detailed part of this, that how to read a chest X-ray. That is completely a different topic. So the International Disease Society of America has defined CAP as an acute infection of the pulmonary parenchyma that is associated, Dr. Pavitra, consolidation. What exactly is this consolidation, if I may ask? If you can tell what exactly, if you understand by the term consolidation, what is a meaning of consolidation? Anyone? Why you call it, there is a consolidation in pneumonia and there is a consolidatory patch which is being said. So what exactly you define it as a consolidation? These are, very minor or very, some will say that, maybe it is a silly question or so, but it is, again, it is a very important to understand what exactly is this if you mean by the term consolidation. It is a stage of pneumonia, I do agree, but I'm just asking the definition of that stage. It is not hardening. It is not hardening, as you know, that lungs has the functional unit that is the alveoli. So alveoli contains air. Yes, air filled lung tissue becomes, yes, it can be, it is not a solidified, yes, it can, you can call it. So there is replacement of the air in the alveoli, either with due to a fluid or a pus or a blood or a cells or any kind of, maybe infection or so. So yes, you are right that air filled lung tissue, it can get solidified, yes, but again there is of course replacement with either of the things, maybe pus, necrotic material, fluid, blood, anything which can be. So the IDSA said that it is accompanied by acute infiltrate on the chest radiograph or auscultatory findings consistent with pneumonia that we have told, either a bronchial breath sounds or a crepitations in a patient not hospitalized or residing in a long-term facility for more than 14 days before the onset of symptoms. So now, if we talk about the epidemiology, the WHO said that the lower respiratory tract, it is, if we talk about the LRTI, most common infectious cause of death worldwide. And you see, it is such a big number, 3.5 million deaths occur yearly. So every year, if we talk about USA, someone is trying to, write it down maybe on the slide. So if we talk of the USA, there are 5 to 10 million cases of CAP, leading to 1.1 million hospitalizations and 45,000 deaths. And if you see also of the Europe, the incidence of LRTI was found to be 44 per thousand in a general practice. So this is a big number. If we talk about Europe, USA, and also in India also. So this is such a big number that because of this, the mortality rate in both continents, although it is less than 1% who do not require hospitalization, but if you see the patients who require hospitalization or admission, the mortality rate goes high from 1% to 12 or 14%, such a big number. So there is always a risk if the patient has come to you with a pneumonia and if he or she is hospitalized or admitted to the intensive care unit, the mortality rate definitely goes to a very higher side. And among those who are admitted to the intensive care unit, who are bacteremic, or those who are admitted from a nursing home, the mortality rate averages from 30 to 40, more high. The patient do shopping from here to there. A small nursing home gets treated, underdiagnosed, misdiagnosed. Again, no proper doses of the drugs which are being given. So this leads to very much increase in the mortality. So although there are no large studies from India on the incidence, but mortality rate are definitely higher. When we talk about the deaths due to LRTI, the number of deaths due to LRTI was 35.1 per 1 lakh back in the year. If we talk about 2008 as, yes, as compared to the, so sorry, yes, as compared to the, yes, so the number of deaths due to LRTI was 35.1 per 1 lakh in the year 2008 compared to 35.8 for the population of TB, while it was 194 per 1 lakh for infectious and parasitic diseases. So around 20% of the mortality, if we talk about in India, are caused by LRTI. So you see again such a big number. So now coming to the first MCQ, and can I have the answers for this? If you can see the MCQ on the, this box. So a 52-year-old man presents with fever, cough, pleuritic chest pain, 3 days, chest auscultation reveals, bronchial breath sounds, crackles, chest X-ray showed new light lower lobe, chest X-ray showed new right lower lobe opacity or a lower zone. He has not been hospitalized in the last 6 months. What is the most appropriate diagnosis? What you will answer to this? Can I have the answers in the chat box? Hospital acquired, community acquired, healthcare, or a ventilator? Everyone is answering B. Definitely. Are you sure community acquired? The patient is hospitalized, so no hospital. Great. So I think everyone who is saying the B answer, yes, please do not type. Please do not type on the this slide part. It is better if you answer in the chat box so that we'll have a productive discussion. So yes, everyone, Anil, Ajit, everyone, Dr. Vivek, yes, you all are right. It is community. Why? Because CAP, as we have discussed, acute infection of the lung pulmonary parenchyma in a patient hospitalized in a long-term facility greater than equal to 14 days with the onset of symptoms with clinical and radiological findings which are being consistent with pneumonia. So I hope you are clear that timing, what exactly is the definition and how you will correlate it with the clinical and radiological findings. So it is a case of CAP. So what exactly, if we talk about the etiology, a microbiological diagnosis could be made only in 40 to 71%. Streptococcus pneumoniae is the most common etiological agent. Some of they say that it is staph or something else. It is not staph. It is a streptococcus pneumoniae which is being there. Viruses are responsible for 10 to 36% of the cases. So the widespread antibiotic misuse is probably responsible for decreasing culture rates. So a patient comes underdosing, maybe overdosing, less duration of the antibiotics. And because of that, you get either a false positive or a false negative report, and you get not a true culture reports. So if we talk about the most common etiology in an outpatient, inpatient who doesn't require a ICU or an inpatient who requires a ICU. So outpatient, strepto, inpatient, non-inpatient ICU. Strepto leads the chart in all three. And then you have mycoplasma, hemophilus, chlamydia, respiratory syncytial in outpatient and also in inpatient non-ICU. But there are some others also like Legionella, aspiration. If we talk about non-ICU, but you see the staff then puts his feet in the patient who is being in ICU inpatient. So there is a staph which has come. There is also a gram-negative bacilli which are being there. So these are again the most common etiologies, and it is again a very important slide if we talk about and this has been taken from the Lancet study, which is the very classical and international study. Risk factors, if we talk about, what are the risk factors? Alcohol intake, yes. COPD, smoker, aspiration, lung abscess, exposure to birds, bats, rabbits, HIV infection, patient of ship traveling, influenza active in the community, cough greater than 2 weeks, endobronchial obstruction, or a IV drug abuser. So for every risk factor, you have a sum of the most commonly encountered pathogens, which if you will do a culture or you will send a routine examination, you will come to isolate the organism accordingly. So there is a risk factor and associated organisms like staph, hemophilus, streptococcus pneumoniae, legionella. So accordingly, there are a lot of organisms which is associated with each of the risk factors. So clinical features suggesting community acquired, but again, it is a MRSA. What exactly is this MRSA? MRSA, anyone? Clinical. So this we are talking about. This is not a pneumonia. This is a community acquired, but it is a MRSA pneumonia. MRSA. So A is aureus. Yes. Anamika, you're right. It is methicillin resistant staph aureus. Yes. So it is a MRSA and methicillin. So how you will differentiate a MRSA pneumonia? Yes, Meghna, Elizabeth, everyone, you are right. It is a methicillin. So how you will differentiate it a normal cap versus a MRSA cap? So you will have a cavity infiltration with or a necrosis. There is buildup of fluid in the pleural cavity known as pleural effusion. gross hemoptysis, blood in sputum. In secondary influenza infection, neutropenia, erythematous rash, skin plus pustules and everything occurring in a previous young or a previous healthy patient, and severe pneumonia during the summer months, not controlled on the routine antibiotics which you have been using. So this is the MRSA pneumonia. So now coming to again one of the MCQ which we have discussed, most common etiologic agent, CAP, Mycoplasma, Strepto, Haemophilus, Staph. Can we have the quick answers? Again, Anamika is saying B. Farhana B. Okay. Again, Dr. Vaishali B. Tayyab. Okay. Except D. Most common I'm talking about. I'm not talking about the all the agents. So there has to be one answer. Na? It is the most common, which leads the group. Dr. Aishwarya, Shiny. So I think every one of you, yes, Riya, Ajay, Bubalan, you're right. So the answer is, of course, Streptococcus remains the most common. Mycoplasma and Haemophilus influenzae are less common causes when we talk about. So you all are right. Dell, MS Alam. So there are very few Indian reports on the etiological agent. So in a study which was being done of blood cultures, again you see strep leads the chart. Then you have Staph aureus, Klebsiella and Haemophilus influenzae in about 8.8%. So an earlier study also found that strep pneumonia to be the most common cause, but it also reported Mycoplasma pneumonia in about 15% of the microbiologically positive cases. So this was the study which was being done at the IGMC Medical College Shimla in the Department of Pulmonary Medicine. So they did a study of clinical and bacteriological profile of CAP in the region of Shimla. So they took 70 patients, and what they found out of the 70 patients, 53 had a known cause, that is a known identifiable organism. 12 patients had a mixed infections, whereas no organisms, they could not isolate no organisms in somewhere 17 patients. So what was the most frequent pathogens out of the 70? They took 53 patients. So in 53 patients, the most common frequent pathogen was Streptococcus pneumoniae, then Klebsiella, Staph, Mycoplasma. So this was the again one of the important study which was being done in the India. So strep pneumonia, common organism, Shimla, Delhi, whereas Pseudomonas predominates blood culture positive pneumonia in Ludhiana. So again, another study was being done in the Sharia Medical College, Kashmir, and again, they looked out for 100 consecutive patients who had blood or sputum cultures. Again, in that, but you see the most common etiological agent in that picture was Pseudomonas. In if this study was which was being done in the Kashmir, then Staph, Klebsiella, and Streptococcus. But again, if you have to choose one organism, it is always Streptococcus pneumoniae which leads the group. If we talk about the diagnosis as we have discussed, it is both clinically and radiographically. So common symptoms like fever, cough, sputum production, shortness of breath, or a pleuritic chest pain will be present along with the crepitations or a bronchial breath sounds, and these can vary over a period of time. Respiratory and non-respiratory symptoms associated with a pneumonic illness are less commonly reported by older patients with pneumonia. Coming to the another MCQ. So a patient suspected with pneumonia, it undergoes a chest X-ray. Which of the following findings is the most diagnostic of CAP? CAP is community acquired, bilateral hyperinflation, new lobar consolidation, diffuse lenticular shadows, or flattened diaphragm. What exactly you think? Patient undergoes a pneumonia, you are suspecting, undergoes a chest X-ray, you are suspecting a pneumonia, and what exactly will be your most diagnostic of CAP? Majority of them are saying B again. Dr. Hiren, Dr. Vivek, Dr. Pratibha. Are you sure? B, neolobar infiltration. There is no diffuse reticular shadows. Okay. Elizabeth, B. Can we have some more answers? Quick. Gladdy. Okay. So, yes, again, you all are right again. So, chest radiograph showing a new focal opacity, either a lobe involvement or a Patchy involvement confirms the diagnosis, whereas hyperinflation, flattened diaphragm, mostly seen in COPD, that is a obstructive airway disease. So you have your answer. So, what is the role of now chest radiograph in the diagnosis of CAP? It is the cornerstone for the diagnosis. So, again, in a study done on 250 ambulatory patient with a febrile LRTI, physician judgment of pneumonia had a sensitivity of 74%, specificity of 84%, negative predictive value 97, and a positive predictive value 27% compared to the chest radiograph. So a diagnosis of CAP can be suspected if at least one, I'm talking about if at least one of the following findings is present in the chest radiograph. That is, a asymmetric increase in lung opacification with a air bronchogram, which is being there, presence of a silute sign. So what exactly you mean by the silute sign? Can anyone say presence of a silute sign? So silute sign is basically it is the outline of the heart. So you have a cardiac silute which is being present. So it represents the outline of the shadow of the heart which is being seen on the chest X-ray, and it usually represents the external borders of the heart. So it represents the external borders of the heart. You have their visualization of the great vessels. So this is a cardiac silute which is being present. So radiographic outline of the heart. It is visualized best on the posterior anterior view again. So either a presence of a silute sign, asymmetric increase in lung opacification, area of increased opacity bounded by a well-defined interface. If only a anteroposterior view is being obtained, increased attenuation of the cardiac shadow for radiographs with a widespread air disease, more asymmetric or multifocal distribution of opacification is being there. So this is the diagnosis of CAP. If you have a chest X-ray, if you have got your chest X-ray done, and if you have any one of the findings which is being there, it is not necessary that all of the findings has to be present. So resolution of the chest radiograph findings may lag behind clinical cure during follow-up, and up to 50% may not show complete radiographic resolution at 4 weeks. So even after 4 weeks of your treatment, there is no 100% complete radiograph or the chest X-ray going back to the normal. So radiographic resolution can be delayed in the elderly population. Lack of partial radiographic resolution by 6 weeks, important. Even in asymptomatic patients with require of thinking of an alternative diagnosis like a endobronchial mass, obstruction, any connective tissue disorders, any organizing pneumonia. So usually the radiograph which is there, you see there is a pneumatic patch which is being there, a complete. So if this radiographic patch doesn't show improvement, even by the 6 weeks, even there is no partial resolution, the radiograph doesn't come back to the normal. You have to think of alternate cause. No, you have already treated the patient for more than 1.5 months, and even if you are not seeing any change, then it has to ring your bell that you're not treating pneumonia. You have to think of an alternate cause. So whenever you have this, feasibility of chest radiograph, you have to get it done. In the absence of availability, the first thing is the clinician's suspicion. It is all your clinical judgment. You have to diagnose, you have to treat the patient. So chest radiograph should be repeated if the patient is not improving. For all those patients who have persistent or worsening of symptoms, or in whom you have to rule out any secondary cause like malignancy. So it is not routinely indicated for the patients who are improving clinically. So until and unless if the patient is clinically deteriorating, or even the patient is neutral, not showing signs of clinical improvement, not deteriorating, you can get a chest radiograph now on a frequent basis. But again, exposing to rays to every time to the patients is not required until and unless you have to rule out any other cause or the patient is not clinically improvement. Now coming to the second diagnostic modality, that is the CT. So CT should not be routinely performed. It should be only performed in those either with a non-resolving pneumonia and for the assessment of complications. Talking about the microbiological investigations, blood cultures should be obtained in all hospitalized and they are not but routinely advised in an outpatient patient. So you're treating the patient on a OPD, you need not to send a blood culture. But once the patient is admitted to the ICU care, you have to send the blood culture when before the administration of the antibiotic. That is very much important. So now blood cultures. Okay, yes. So the third part, an initial sputum gram stain and culture or an invasive respiratory sample as appropriate should be obtained in all hospitalized patient. Very important. If you have collected the sputum or if the patient is on ventilator, you are sending a endotracheal tube specimen. It is very important you do not send the sputum just for culture. You send for a sputum routine, for a AFB, for a CB-NAT to rule out TB, sputum culture, pyogenic culture, fungal culture, gram stain, cytology. So you have to send every aspect of the sputum. So sputum quality is very much important. And again, sputum AFB should also be obtained. RNTCP now it has been changed to the NTEP guidelines which are being there. Pneumococcal antigen detection test not routinely required. Pneumococcal PCR again not recommended as a routine diagnostic test. Legionella urinary antigen test is desirable for patients with severe CAP, but there are challenges to this test. First is it is not available everywhere, and again it is a bit expensive when talking about the treatment. So maybe some of the patients or majority of the patients, if we talk about an Indian scenario, won't be able to afford the test. So it is not appropriately available at each and every place. Investigations for atypical pathogens like mycobacteria, mycoplasma, chlamydia need not be routinely done. So general investigations in an outpatient setting, again, you can skip it. Maybe you can get a chest X-ray done and that's it. Pulse oximetry, check for the pulse oxygen saturation levels, his pulse rate or heart rate. Pulse oximetric saturation should be obtained as early as possible in admitted patients. Very much important because the patient needs oxygen support or not. And an ABG should be immediately performed to assess whether the patient is in a hypoxic or a hypercapnic respiratory failure, type 1 or type 2. But again, if the patient is in pneumonia, most commonly he will be in a type 1 or a hypoxemic respiratory failure, which is being there. Blood glucose, along with that, blood glucose, urea, electrolytes should be sent in all the hospitalized patients. So full blood count, liver function tests are also available along with all the routine investigations. PCT, CRP, you don't need not be performed again because these are non-specific markers of inflammation. So if the patient has inflammation, these parameters will be raised only, CRP, ESR. But again, to monitor the prognosis of the patient, this can be done that the infection or the infection is settling down. So again, now what are the indications if you want to go for a extensive diagnostic testing? So patient admitted in a ICU, you send a blood culture, you send a sputum culture, Legionella urinary antigen test, yes. Pneumococcal urinary antigen test and some other tests, important. For leukopenia, if you see the fourth, blood culture, pneumococcal urinary antigen test will work. Active alcohol abuse, all except some other test, you can skip it. For severe obstructive lung disease, just the sputum culture. Again, if you have a pleural effusion, you need to send all. If you have just positive pneumococcal urinary antigen, a blood or a sputum culture will do. So accordingly, based on the indications, based on the criteria, these all tests can be performed. But again, if you see the first criteria, important, everything you have to send. And again, if there is a cavity infiltrations, you are suspecting MRSA, blood, sputum, some other tests, you can skip the urinary antigen test, which is being there. Coming to the MCQ, WHO estimates LRTI is responsible for approximately how many deaths? What exactly you think? How many deaths worldwide each year? What exactly you think? 0.5, 1, 2 million, 3.5 million. So you've gone with the maximum, that is the 3.5. Everyone is saying the D answer. Ray, Elizabeth. Okay, most of them are saying D only. Yes, you are right. 3.5 million. Most common infectious cause of death with 3.5 million deaths annually. You see, such a big number. such a big number, and this can be prevented if the pneumonia is not misdiagnosed, undertreated. So should the patients with CAP be risk stratified? What should be the optimum method? Patients should be risk stratified, important, should be performed in two steps. That is whether the patient is a non-ICU case versus a ICU case. So initial assessment should be done with CRB scoring. We'll be seeing in the further slides what exactly is this CRB scoring which is being there. If the score is greater than 1, consider the patient for admission. So pulse oximetry used to admit the hypoxemic patients, and how you will define it a hypoxemia. Oxygen saturation less than equal to 92 and 90% for age less than equal to 50 and greater than equal to 50 years. So patients selected for admissions can be triaged according to whether a non-ICU case or a ICU case. If any major criteria or greater than 3 minor criteria are fulfilled, patient should be admitted to the ICU. So you see this, the patient presents with the clinical symptoms, cough, shortness of breath, temperature, new focal chest signs. If you have a chest radiograph available, yes, very good. Look out for the cardiac solute, patchy consolidation, infiltrates. If these are absent, again, and if you have ruled out clinically, very important, then you have to think of alternative diagnosis. But again, present, calculate the CRB 65 score. Again, if you don't have a chest X-ray, you also calculate the CRB. Less than 1, go for a pulse oxygen saturation. Again, less than 92, less than 50, less than 90 for 50. If no, the saturation levels are above this level, you manage the patient on a OPD basis. If yes, admit, do a chest radiograph, send all the blood cultures, urea, arterial blood samples, everything. And after sending all the cultures and so, you administered the first antibiotic dose, very important. And then you decide whether the patient requires a ICU or a non-ICU. If requires a ICU, you can perform the further test like a creatinine, Legionella antigen test or so. Now, these are the various scores which are being there. That is the curve, CRB, SMART COPS, SMRT, CO, and ATS IDSA criteria. So what is this curve 65? So curve has 4 parameters: C for confusion, U for urea, R for respiratory rate, and B for blood pressure. Confusion, urea greater than equal to 7, respiratory rate greater than equal to 30, BP diastolic less than 60, systolic less than 90. And what is this 65? It is age. So you have curve, you have CRB, and what exactly you have a smart cop. You have a blood pressure there. In a smart cop, you also have a chest X-ray multilobar involvement, low albumin that is less than 3.5, tachypnea, tachycardia greater than 25, greater than 125, confusion, along with poor oxygenation less than 70 or SpO2 less than 93. SMRT-CO, BP, multilobar, respiratory rate, tachycardia, and just poor oxygenation. So you have a ATS-IDSA criteria in which they have given a major and a minor criteria. Major, patient on ventilator, septic shock, needing inotropes. Minor, tachycardia greater than 30, PaO2 by FiO2 less than 250, and this you calculate it through the patient is on ventilator, the fractional inhaled oxygen you are giving, along with the partial pressure of oxygen, multilobar involvement, confusion, uremia, leukopenia, thrombocytopenia, and hypothermia. So these are the various scores which are being there. Now, the difference between curve and CRB 65 is that CRB, what it does? Includes urea, excludes urea, includes oxygen saturation, uses ABG. Can we have the answer? Just now we have discussed the curve and the CRB score, and it is very standard score. You have to keep this in mind. Someone is saying A, someone is saying B. CRB, just look at the question that CRB score includes, excludes, includes, and uses. So, Dr. Pratibha, B, Aromal, B, what exactly? Okay, B, we are getting Ray, Glady, B. It excludes urea, sure. Yes, it excludes urea because CRB 65 lab results are unavailable, and again CRB can be performed on a primary or a outpatient use also. So now I'm so sorry, we have the answer over here. So 67-year-old women with a fever, confusion, RR 30, BP 90 by 60, BUN 25, diagnosed with CAP. So curve score is already, if we have the answer, if you see how you will calculate. So the patient has confusion. So you give it as a 1 point. Respiratory rate, urea greater than 20. Yes, it is 25. Again, 1 point. RR greater than equal to 30. Yes, 1 point. BP less than equal to 60. 90 by 60, 1 point. So 4. And age as it is greater than equal to 65, 1 point more. So it everything adds to a point, and each point corresponds to a total 5 score that indicates a very high mortality and requires a ICU admission. So this is another score which is being there, that is the PSI, that is the pneumonia severity index. So you have a step 1 without score, step 2 with scoring, age greater than equal to 50 years, comorbidity like active neoplastic disease, heart failure, stroke, renal disease, chronic liver disease. What exactly is this clinical condition? Patient is deteriorated, heart rate greater than equal to 125, respiratory rate greater than 30, RR less than 90, that is the systolic BP, and temperature less than 35 or greater than 40. So if everything is a no, you put it in a class 1, and it has a mortality of just 0.1. If it is a that step 1 age greater than 50, step 2 if you see, and if you have this all the blood tests also which are being there, and if you see in the blood test pH less than 7.3, that is the acidosis, urea severe uremic, sodium less than 130, hyponatremic, glucose greater than 14, hematocrit, PO2 less than 60, and everything has been given a score. You see this arrow, plus 30 plus 10. So everything has been given as a score. Neoplastic 30, heart failure 10, heart rate 10, respiratory rate 20, systolic BP less than 90, 20, pH less than 7.3 plus 30. So if you club everything, class 1 which we have discussed, everything no. Class 2, if you club everything, score is less than 70. That means 2 from this, 1 from this. If less than 70, it has a mortality of 0.6, 71 to 90, mortality of 0.9, 91 to 130 is 9.3, greater than 120, 27. So you see with clubbing of these scores, as the score going high, the mortality is also increasing, and this is the pneumonia severity index, another tool to classify it. So you see this? Total points, 30-day mortality, and an outpatient, which is being there. So this is the minor and major criteria which we have already discussed. So now evaluation, you do a chest radiograph, you have a history, you perform a physical examination, no infiltrate, manage again and look out for the alternative diagnosis. If I infiltrate, supporting diagnosis of pneumonia is present, either do a pneumonia severity index, do a curve 65 scoring, look out for the hypoxemic signs, and manage as an outpatient patient. What if the patient is of a pneumonia severity index risk 1 to 3, curve 0 to 1? So you see, if it has a score of 0 to 1, you can manage outpatient. 1 to 3 pneumonia severity index, you manage OPD, give an empirical therapy. Again, if the score is more, hospitalize the patient, class 3, 4, 5, curve greater than equal to 2, along with the mitigating factors like poor response to oral therapy, unstable living condition also. Now coming to the antibiotics, it should be administered as early as possible and should be targeted towards the most common organisms. So what exactly is the recommended dose of antibiotics? If we talk about oral macrolides, azithromycin or oral amoxicillin, 500 to 1000 mg TID for a patient outpatient. For an outpatient patient, you are treating a patient, double antibiotic regime of amoxicillin and a macrolide has to be given accordingly with a beta lactam and a oral macrolide. So for outpatients, if you have a comorbidity, oral combination beta-lactam plus macrolide, there is insufficient evidence for tetracyclines, fluoroquinolone should not be used, and antibiotics should be given in appropriate doses. So indications for empirical combination therapy, if you have a comorbid medical conditions like chronic heart, lung, liver disease, diabetes, alcohol, malignancies, and you see the doses of drugs Amoxicillin, which we have talked about, 1 gram TID. Azithromycin, 500 milligram OD. Then you have ceftriaxone, 1 to 2 gram BD, cefepime, 1 to 2 gram BD or TID. And these are given IV. So azithromycin mostly per oral, and amoxicillin if you're managing the patient on an outpatient. For an inpatient, if you have admitted the patient but he or she is a non-ICU patient, regimen is a beta-lactam plus macrolide like cefotaxime, ceftriaxone, amoxicillin, clavulanic acid. If you have a hypersensitivity to beta-lactams, you can give a fluoroquinolones like Levoflox 750 OD. And it may also be used in a, as you know, it is a MDR regimen drug, levofloxacin. So the patients along with this should also definitely undergo a AFB testing. So route of administration should be decided based on the clinical criteria or the clinical condition of the patient. So a 40-year-old healthy man presents with mild care. Most appropriate empirical antibiotic regimen. Quick. Can we have the answer? 40-year-old healthy, mild care. Oral levoflox, oral amoxicillin, IV ceftriaxone, azithro, piperacillin, tazobactam, the most common piptas, which we give. Most of them are saying B. And you're right. Yes, 40-year-old man, healthy. So you have to go for, you can manage it as a OPD case, no? Double antibiotic. He doesn't have any comorbidities. So you go for a oral amoxicillin and a azithromycin. For a patient admitted in a ICU, recommended regimen is beta-lactam, cefotaxime, amoxicillin plus a macrolide without risk factors for Pseudomonas aeruginosa. If Pseudomonas aeruginosa is the etiological cause, give an anti-pseudomonal antibiotic like ceftazidime, piperacillin, tazobactam, imipenem, meropenem. So combination therapy may be considered with addition of aminoglycosides or anti-pseudomonal fluoroquinolones like ciprofloxacin. Fluoroquinolones may be used in TB if not a diagnostic consideration. So again, he or she should also undergo a AFB testing. Again, if you have the culture reports, you can alternatively change based on the culture reports. So again, diagnostic therapeutic intervention should be done if the patient develops a recurrent pleural effusion. You can do a pleural tapping or an insertion of the ICD. But again, if the patient does not respond to your treatment within 2 to 3 days, 48 to 72 hours, very important time period, he should be evaluated for the cause of non-response, including any development of complications, atypical pathogens, or if the patient is developing a drug resistance. So 3 days is good to assess the response of the patient. So again, recommended empirical antibiotic for cough, which we have discussed, outpatient, previously healthy, no use of antimicrobial. Macrolide, level 1 evidence, doxycycline, weak recommendation, level 3. But again, if a presence of comorbidities is being there, a respiratory fluoroquinolone, a beta-lactam plus macrolide. And again, if you're suspecting a high MIC, macrolide resistant streptococcus pneumoniae, you can use these regimens which are being there. So in patients non-ICU, fluoroquinolones, beta-lactam plus macrolide. In patient ICU, beta-lactam, special concerns has to be given for the Pseudomonas if it is being there. So you have to give a beta-lactam, maybe in combination with the aminoglycoside, azithromycin, or beta-lactam plus aminoglycoside along with the anti-pseudomonal fluoroquinolones has to be given. So this is the various recommended antibiotic therapy based on these specific pathogens which are being there. So penicillin non-resistance, less MIC, greater MIC. So based on this, preferred antibiotic is penicillin or amoxicillin. Agents should be susceptibility including cefotaxime, ceftriaxone or fluoroquinolones. So again, based on if you have a Legionella, fluoroquinolones, azithromycin, alternative antibiotic, a doxycycline can be given. Hemophilus, non-beta lactamase, amoxicillin, alternative fluoroquinolones, doxy. Second or third generation, if it is a beta lactamase, along with the alternative of fluoroquinolones or a doxycycline. So accordingly, you give the regimen based on the type of organisms you have on the culture. So 68-year-old man, multilobar pneumonia, hypotension, need vasopressors. Which empirical therapy is most appropriate? What exactly you think? Cefixime, doxycycline, amoxicillin alone, or piperacillin tazobactam with azithromycin? You see how macrolide is important? Noshiba A, Shiny A, Dr. Pradyuman A, Sheila, Dr. Hiren, Ria. Yes, it has to be a piperacillin tazobactam. So severe cap, it is a severe multilobar involvement, patient having low BP, needing vasopressor support. So you need a beta-lactam anti-pseudomonal regimen, macrolide. So if pseudomonas risk persists, use piperacillin tazobactam, cefepime, meropenem with a macrolide can also be given. So when should be the patient be discharged? You have already put the patient on antibiotic. Switch from oral to IV is safe. After clinical improvement, switch to oral. That means you have started with IV, switch to oral. If it has been switched from severe to moderate. Patient will be considered for discharge if they have started taking oral intake, fever has gone down, hemodynamically stable, but everything for a period of at least 48 hours. Outpatient should be treated for 5 days and inpatient should be treated for 7 days. Antibiotics should be continued beyond this period. Very important. Antibiotics may also be continued beyond a specific period for those with meningitis, gram-negative bacilli, lung abscess, empyema, if initial therapy was not against this identifiable pathogen. So duration of the therapy, so patient with a CAP treated for minimum 5 days should be febrile again for 48 to 72 hours. A longer therapy need if the patient have, endocarditis, meningitis, extra pulmonary improvement. Signs of clinical improvement, temperature gone down, heart rate gone down, respiratory gone down, BP improved, arterial oxygen saturations improved, oral intake better, and a normal mental status of the patient. Role of biomarkers should not be routinely used. Now, what adjunctive therapies, if you have to give, steroids are not routinely recommended for non-severe. Steroids, when only used for septic shock, if the patient is in acute respiratory distress syndrome, secondary to CAP, there is no role of adjunctive therapies like anticoagulants, immunoglobulins, granulocyte colony stimulating factors, chest physiotherapy, antiplatelet drugs, inhaled nitric oxide acting as a vasodilator. So again, this doesn't have any role in the management of CAP. But again, routine use of pneumococcal vaccine among healthy immunocompetent adults for prevention of CAP is not recommended. Pneumococcal vaccine may be considered in special populations who are at high risk, like a patient of cancer, malignancy, immunocompromised, diabetes. So these are the patients, they need a pneumococcal vaccine. Influenza vaccines should be considered for adults. Smoking cessation should be advised. Very important. So high risk, this was the talking about diabetes, alcohol, CSF leak, influenza, various cardiorespiratory or pulmonary renal dysfunction. So these are the patients who are high risk and they need a vaccination. Oh, although this has the answer, but again, pneumococcal vaccination recommendation, routine pneumococcal vaccination is recommended for. So this already has the answer, adults with a chronic illness or a immunocompromise. So this is the routine when you will order a pneumococcal vaccination. Coming to the second, which is the hospital acquired or a ventilator acquired pneumonia, which is being there. So now coming to the MCQ, hospital acquired pneumonia defined as pneumonia that develops within 24, 48, greater than or equal to 48 hours or within 7 days. Can we have the quick answers? Hospital acquired pneumonia. C. Okay, Bubalan is saying C. Farhana. C. C. Rajveer. Twinkle. Okay, Ray is saying C. So we are talking about the hospital acquired. We have now switched to the second part. And if you see, I hope the cap is very much clear, community acquired. So hospital acquired pneumonia is definitely the pneumonia greater than or equal to 48 hours. It has to be developed now in a hospital. So after hospital administration greater than equal to 48 hours. Ventilatory acquired, that is the VAP, greater than equal to 48 hours after the patient is on ventilator. So you have HAP or VAP. So HAP is a inflammatory condition greater than developing after 48 hours. It can be classified as a ICU acquired or a non-ICU acquired depending upon the place where it have occurred. VAP, again, same after 48 hours, but again, the patient is on ventilator. So patients who develop pneumonia while being assisted with NIV are considered to have hospital acquired rather than VAP as the upper airway defense mechanisms remain intact. This is the non-invasive ventilation. Now the patient is not on ventilator. So you will club this patient in a HAP, not VAP. So what exactly is this HCAP? That is the healthcare associated. So pneumonia developing in the population's hospitalization in a acute care hospital for 2 or more days within 90 days of the infection, residence in a nursing home, long care facility, recent IV antibiotic therapy, chemotherapy, wound care within 30 days, and attendance at the hemodialysis clinic. So pneumonia that occurs in the following patient populations. So criteria, hospitalization for greater than equal to 2 days, long-term infusion therapy, hemodialysis, home wound care, and pneumonia specific criteria, non-ambulatory, tube feedings, immunocompromised, and use of gastric acid suppressive drugs. However, there is no, there is not a well standardized definition of healthcare. So there is a heterogeneity in defining the HCAP. So whether HCAP is a separate entity or a subgroup, again, it is unclear. So this has been a lot of studies has been done, but again, it has been a unclear scenario. If we talk about the burden of hospital and the ventilatory, they acquire for about 25% of all ICU infections, which is being there. So the crude mortality rate may be as high as 30 to 70%. So the risk is the highest early in the course of hospital stay. Risk of VAP 3% per day during the first 5 days, and as the days passed by, the percentage decreases. 2% day 5 to 10 and 1% thereafter. So you see this? So approximately half of all episodes of VAP occur within the first 4 days of mechanical ventilation. The intubation process itself contributes to the risk of infection as evidenced by low occurrence of HAP in the non-ventilated. So this we have talked about early and late onset, two categories. Early, within the first 4 days of hospitalization, it has a better prognosis caused by antibiotic sensitivity. Late, day after 5, again can be caused by MDR pathogens and can be associated with a higher mortality and morbidity. So risk factors for multi-drug resistance for hospital acquired. So these are, the presence of risk factors, which we have talked about: immunosuppressive therapy, chronic dialysis, home wound care, again, residence in a nursing home. So the incidence of VAP ranges from 16 to 53. Most Indian data which we have till now are from the tertiary hospitals and medical ICUs and may not be truly representatives of other settings. So these are the various studies which we have done at the various premier institutes like Sanjay Gandhi, Escorts, GMC Mumbai, PGI Chandigarh, and they have been done over a period of time. And diagnostic criteria, they have taken other bronchoalveolar lavage and where the patient was admitted. So accordingly, they have calculated the incidence of hospital acquired and VAP. So 53.9% the incidence of HAP and VAP. If we talk about SGPGI in a patient admitted in SICU, and in a patient of AIMS, 35% in a patient admitted in a ICU, KMC, Kasturba, Manipal, 45% in a medical ICU. So these are the various incidents of HAP and VAP which are being occurred. So caused by wide spectrum of bacterial pathogens, and common pathogens are gram-negative bacilli such as Pseudomonas aeruginosa, E. coli, Klebsiella pneumoniae, Acinetobacter. Infections due to gram-positive Staph aureus, particularly MRSA, are also rapidly emerging. And pneumonia due to Staph aureus is reportedly more common in the patients with diabetes, head trauma, and those hospitalized. Again, gram-negative still remain the most common. Again, after gram negative, if we talk about Acinetobacter has been there as the most common organism. So percentage of incidence of organisms causing VAP in India and US. So in Pseudomonas aeruginosa, India 40, but again 24 in US, and then Acinetobacter, and accordingly you have Enterobacteriaceae, and then the various organisms, Streptococcus, Maltophilia, Haemophilus influenzae, and Neisseria. Clinical conditions associated with likely pathogens in healthcare associated. So hospitalization for greater than equal to 48 hours. MRSA pathogen can be Pseudomonas aeruginosa, Acinetobacter, MDR. Chronic dialysis, just think for MRSA. Home infusion therapy, wound care, family member. So accordingly, various clinical conditions and the various pathogens. So Indian ICUs most frequently associated with most frequent organism, ventilatory associated pneumonia. What exactly you think? Can I have the answer? Quick. Indian scenario we have been talking about, ventilatory associated pneumonia, strep, Myco-Acinetobacter or Staphylo. Majority of them are saying C. So yes, the answer is C. Gram-negative organisms, Acinetobacter and Pseudomonas are the leading cause of HAP and VAP, which we have discussed. So they should be suspected in any hospitalized or the patient on ventilator. And the criteria to diagnose is new or progressive radiographic deterioration, along with two of the important findings, either a new onset of fever, purulent secretions, leukocytosis, or a decrease in oxygen saturation levels. Modified CDC criteria for diagnosis of HAP and VAP. Again, an important table, which I tell you. Fever, leukopenia, altered mental status, purulent infusions, purulent sputum, worsening of the gas exchange, new onset of cough dyspnea, or a bronchial breath sounds, or a rales or crepitations. So this is the CDC criteria which we have given, which they have given for the diagnosis of HAP and VAP. So they should be clinically defined. So in a patient who have been strong suspected, periodic evaluation has to be done. And you have to send this LRTI sample, blood culture, sputum cultures. If sputum patient is unable to expectorate, you either perform a bronchoalveolar lavage and you send a better quality of sputum. So a good quality has to be sent. CT should not be routinely performed and semi-qualitative culture should be performed. So again, now modified clinical pulmonary infection score, that is the CPIS score. So it is based on 0, 1, 2 tracheal secretions, rare, 0, 1 abundant, 2 abundant and purulent. So accordingly, they have been given based on the criteria of X-ray infiltrates, temperature, leukocytosis, PaO2 by FiO2 and microbiological scoring. Now coming to this, you have this chest radiography, you have at least two of the criteria which we discussed. Criteria fulfilled, you send a sputum or a tracheal aspirate. Start empirical antibiotics, clinical reassessment after 72 hours, patient improving, culture negative. Clinically pulmonary index scoring less than 6, stop the therapy. Greater than equal to 6, give a short course therapy. Again, but the patient improving, culture positive, de-escalate antibiotic short-term therapy for 8 to 10, 14 days. Criteria not fulfilled, consider a non-infective etiology, still not unfulfilled, then the diagnosis of pneumonia is unlikely. But again, if after clinical reassessment of this criteria fulfillment, patient is not improving, culture positive, change the antibiotic, culture negative, repeat microbiological workup and search for the fungal cause or non-infective causes. HAP suspected, so this is again accordingly which we perform. So role of biomarkers should not be routinely done, but again when you have access to them, serum procalcitonin levels less than 0.5 may help in differentiating a bacterial from a non-infective etiologies. So suspected HAP, send endotracheal bronchial, early infection, no MDR, treat like a severe community acquired, late infection, high risk of MDR, broad spectrum therapy for MDR pathogens. So patient of HAP administered the antibiotic as important and the combination therapy should be given despite of a monotherapy. So initial empirical therapy, if we talk about, Anti-pseudomonal penicillin, third or fourth generations. Anti-pseudomonal carbamazepines, monobactam, you can choose anyone, plus aminoglycosides, fluoroquinolones. Add a MRSA cover if you have a high prevalence of MRSA, and the best is vancomycin or teicoplanin. So these are the doses of IV antibiotics used in treatment of HAP and VAP, beta-lactams, carbamazepam, anti-pseudomonal, aminoglycosides, quinolones, anti-MRSA, that is Vanco and Tico, linezolid, polymyxins, that is the colistin and the polymyxin B. So again, the IDSA guidelines have again for a hospital for MRSA, which we have told about. So ventilatory acquired pneumonia in patients with no known risk factors for multi-drug resistance. So if you have this potential pathogen of Streptococcus pneumoniae, and if you're suspecting a HAP or VAP, recommended antibiotic is ceftriaxone, levofloxacin, ampicillin, ertapenem if you are suspecting a potential pathogen accordingly. So is antibiotic de-escalation useful? So it is strongly recommended. It based on you have the microbiologically reports, the patient clinically condition, the pulmonary infiltrates is being identified, and if it is being clinically improvement. So if cultures are sent after the administration of antibiotics, and if there has been improvement in the further culture reports, and antibiotic should be continued for 7 days, followed by the assessment of clinical pulmonary index scoring on the seventh day. If the score comes less than 6, antibiotic stop. Again, greater than equal to 6, continue the antibiotic for 10 to 14 days. Optimal duration of therapy when due to Pseudomonas acinetobacter and MRSA, longer duration for 14 days, and assessment has to be done accordingly. Drug of choice for MRSA, as I already told, the two golden drugs, Vanco and Teicoplanin has to be there. Linezolid, as it is a MDR drug, it has to be chosen, very important. And also it has to be chosen very carefully if the patient has a renal failure, or again, if the patient is vancomycin intolerant, has a renal failure, harboring vancomycin resistant organism, then you can switch to a linezolid dose. So for MDR Acinetobacter, you give a carbapenem, colistin, polymyxin B, a combination therapy with sulbactam or colistin or a carbapenem for MDR Acinetobacter may be initiated. Sulbactam may be stopped after 5 days. So for treatment of MDR Pseudomonas, combination chemotherapy with a carbapenem and either a fluoroquinolone or an aminoglycoside is recommended. Then you de-escalate accordingly. So for a patient with VAP, due to Acinetobacter or Pseudomonas, the recommended duration of antibiotic therapy is 5, 7, 10, 14. Quick. 5, 7, 10, 14. Can we have the answer? 14. Okay, 14 days. D. Most of them are saying D. So yes, because it is a MDR pathogen, it is a Acinetobacter, 14 days of antibiotic therapy is required, or else with a good clinical response, 7 days is adequate. Now, these are the, following strategies like, closed suction systems, use of sedation, hand hygiene, oral cavity, proper suctioning, proper sterilization. So these are very much important. Stress bleeding prophylaxis, transfusion is being required. Again, if the patient is hyperglycemic, you give a insulin therapy accordingly. If the patient needs a blood transfusion, you give a red blood cell or uh, accordingly treatment. So 67-year-old women who has 2-day history of productive cough, fever, altered behavior brought to the casualty. Vital signs you see: temperature more, BP bit on the higher side, heart rate 120, respiratory rate 30, SpO2 91. There has been Krebs, lab result a bit of neutropenia, sodium less, infiltrates in both lower lobes. What exactly you think where the patient should be treated, and what initial antibiotics should she be started on? What should you think based on the clinical condition whether the patient should be treated as a OPD or IPD? Based on the lab reports and based on the clinical condition of the patient. Twinkle is saying IPD, Aromal IPD, IPD, initial antibiotic. So now you calculate the curve scoring in this. So what exactly you will see? There has been a confusion in female. Yes. 1 greater than 20. You see this now. You see this. You have seen this. 1, you have 25. The patient is altered behavior. So confusion, yes. 1, yes. Respiratory rate was more. You see what exactly? 30. Age greater than equal to 65 years. So you have 4 parameters now, which are being correct. So you have scored 4 points. This should be treated as an inpatient, as a ICU patient. So based on the curve scoring, you can calculate where to treat patient. So again, minor and major criteria, this we have already discussed, and this is again the important criteria. What exactly is this? So if we talk about this, if we going back into the case, respiratory rate was greater than 30, yes. Chest X-ray had multilobar involvement, yes. Confusion was there, bun was there. And based on this report, what exactly is this? So the pneumonia severity index of 4 has come out to be, if you have pulled all the parameters in this report, respiratory rate, everything, and this is again electronically calculated score. Alternate mental status, respiratory rate, age, and all the findings are being there in this chart, which you can calculate online also. So based on this, a score 107 was generated, class 4. Class 4, mortality 9.1 score. So hospitalization is recommended for class 4 and 5. Class 3 should be based on the clinical judgment purely, whether the patient require a ICU or not. So initial antibiotics, ceftriaxone and azithromycin. So a patient with VAP due to Acinetobacter or Pseudomonas, this we have already discussed, I think. So 5, 7, 10, 14. Yes, this we have already discussed. So it is 14. Now, corticosteroids are recommended in CAP with, this we have discussed, mild, non-severe ARDS or all CAP patients. Where exactly you will recommend piperacillin, tazobactam, twinkle, you can start with, but again, it is better before going to the piperacillin, you have your blood cultures report, and if the patient is clinically giving you time, again, it is based on the clinical judgment. So corticosteroids, when we have discussed this, C, most of them are saying C only. So the answer is yes. Until and unless the patient have a ARDS landing up into a respiratory failure or going into a shock, you don't give steroid on a regularly basis na, for pneumonia. It will in fact flare up the pneumonia. So which statement regarding biomarkers in CAP is correct? They should be routinely done. They reliably predict. They are not routinely recommended. They replace the microbiologically testing. So we have discussed this also, CRP, PCT in CAP. Can we have the quick answer? They should be, whether they should be performed routinely or they should not be performed. C, 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 majority of them are saying C, 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 C. So yes, they are not recommended, routinely recommended. No? So even the standard guidelines haven't been given a routine in their routine. The most effective strategy for CAP among individuals is regular antibiotic intake, smoking cessation, vitamin supplementation, or daily bronchodilators. What exactly you think? Bubalan is saying, okay, B, aromal B, vitamin, daily bronchodilators. Twinkle is saying B, B. Okay, so yes, smoking cessation, na? It is a major modifiable risk factor. So yes, I think I've covered all the, especially if we talk about the pneumonia. So we have discussed majority of the types of the, all the types of community acquired, hospital acquired, ventilatory acquired pneumonia. We'll be needing again, if we want to discuss a viral or a fungal pneumonia in detail, then again we'll be needing one more session to cover that. And again, I think we can be able to take up that session also if we want another, uh, session for that also. So any questions, I'm open to answer. Thank you very much. The certificate link will definitely, and it will take on the, and or the pus plural. Yes.
Then we are open for the Q&A session now. Please drop in your questions at the chat box so that the Dr. Ayush will be able to read it and answer to your questions. And yes, certificate link will be shared Please wait till at the last. The session is not. We will share the link. Thank you.
So I hope the treatment guidelines are very clear, and it should be not a single antibiotic approach. It is always a double combo antibiotic. So Bubulan is saying, why use a third generation cephalosporin only, not interested fourth and fifth? So that was your question, Bubulan, or you wanted to say why are we using a third generation? So if your question was why exactly are we going for a third generation, basically third generation antibiotic, if we talk about like ceftriaxone, which we commonly use, or a cefotaxime or a ceftazidime, which we use, they have a broader antibacterial action. When talking about and broader antibacterial spectrum has been there, and they cover basically both gram positive, gram negative. So their wider coverage, and they have a bit of more clinical edge if we talk about their antibacterial action in community acquired pneumonia and also in hospital acquired pneumonia. So because of that slightly edge which they have, because of their a slight bit of more antibacterial action, a slight bit of covering of both gram positive and gram negative, so they are being a good choice of using along with the macrolides or a fluoroquinolones if they are being indicated. So Suraj, curve 65 pneumonia severity based on the all parameters which you have available. It is completely based on your clinical judgment, whether you have, curve 65 is a bit it is a bit less cumbersome than compared to the pneumonia severity, because you see pneumonia severity index, there was a lot of parameters, neoplastic lesions, pathology, and everything has been given a score of 10, 30, 40. But if you have all the parameters available, you can go for a pneumonia severity index. But again, curve 65 is also equally good as compared if we talk about pneumonia severity index. So a curve 65, if the patient comes to you, the patient has a altered consciousness, you send a urea count, you send a bun count, you see his respiratory rate, you see his blood pressure. So based on the all the immediate, which you have this thing in your hand, definitely you can go for a curve 65 scoring than compared to the pneumonia severity index. Dhania powder. More chance of getting resistance, more chance, yes, but again, if you see, it has a good lung penetration. If we talk about third generation, beta lactamase activity has been also good. If we talking about the gram negative organisms, it covers, as I already told, cap and hap organisms, and outcomes and safety has also been good if we talk about the third generation third generations antibiotic which you have talked about.
Doctors, we have pasted a social certificate link in the chat box. Also, you can ask your question. Dr. Ayush will be able to answer all your questions. And the doctor, so many people are sending thank you. Thank you so much. This kind of appreciation is what moves us doing such webinars. Excellent session. Thank you so much. A doctor from
Yes.
St. Joseph College of Nursing says, thank you so much. Nothing. Excellent, sir. I
Thank you,
think,
everyone. Yes.
yeah. I'll. I- Okay. So, thank you all. I'll be pasting our social media links in the chat box. Please do follow us on social media to know more about webinars, because we are coming up with a lot of webinars. Uh, I have also pasted again the certificate registration form. Please go there register it, and you will get the certificate by 2 working days. And yeah, thank you, doctor. Thank you for this insightful session. I personally learned a great deal. I am sure all of the doctors here would agree with me. On behalf of everyone, I would extend my sincere gratitude to Dr. Ayush Pandey. With his tight schedule, he always somehow make his time to dedicate his 1.5 hour to us. It is this kind, and it is kind of this engagement would really moves us, motivates us to organize more such webinars. Thank you all for joining today. We hope you found this webinar informative and valuable. If you have any further queries or questions, would you like to more information, please feel to reach out to us. Additionally, we have already dropped the certificate link, the social media links. Go there, follow. We are posting a lot of informative stuff, and we are also coming with a lot of interesting stuff. Do follow us on social media. Do get to know about us, and thank you. Thank you all. Thank you,
Thank you,
Dr. Raj.
everyone. Yeah. So thanks to Team Mediversal. Thank you. Thanks, Vijay.
Thank you.
And yeah.
Happy learning all. We'll see you in another webinar. We have another webinar on 11th. Keep active in the groups. We'll be posting all the links. Happy learning. The more you learn, the more you serve. And we at Mediversal Academy believe one statement called Vaidyo Narayana. That is something we strongly believe. Uh, Thank you so much. Thank you for joining. We'll see you on another webinar. Thank you, Doctor.